Welcome to AETCM, the emergency medicine channel. So already we know we started the respiratory emergencies. Nowadays we are discussing the last three part we discussed already. This is the fourth part. Here we are going to see something regarding the common respiratory conditions. So first in this part, first thing is a pulmonary infection. In this specifically here we are going to see is a pneumonia. See pneumonia, what is mean by pneumonia? Pneumonia is an inflammation and consolidation of the lung parenchyma. It is because of the infection or inhalation of any foreign particles. So here two terms, so pneumonia in the sense any inflammation or consolidation of the lung parenchyma. Inflammation already we know, consolidation means it become a more solid, so the lung parenchyma become a more solid because of the any other infection due to a virus or any fungus or any bacteria. So in this virus, fungus, bacteria is the most common one. So otherwise, because of the infection or it because of the inhalation of any foreign particles. So how we are classifying means according to the causative organism, according to the environment, according to the areas, which area of the lung affected, according to the causes. So one by one, according to the causative organism means we told bacterial, viral, fungal. So bacterial in the sense more common bacteria is a Streptococcus, pneumonia is a more common one, and then other bacteria like a Staphylococcus aureus, it's a one of the other bacteria. These are the common bacteria. Virus wise, we have a rhinovirus is one of the bacteria, and then HIV virus also one of the thing, and then nowadays more peaking bacteria, this one peaking viral, no, that is a coronavirus, that is also one of the common cause. Fungal wise, you have aspergillosis and then we have a candidiasis. So these are the common fungal organism that is causing the pneumonia. Second thing is an according to the environment. So it is because of the community acquired pneumonia or hospital acquired pneumonia or ventilator associated pneumonia. So by reading this you can understand something. So community acquired pneumonia means, so by reading this we can understand the source of infection from the community. It is because of the community acquired. So not because of the hospitalization or not because of the being in ventilator. So only the source of infection from the community. There's a community acquired pneumonia. Most common organism is a Streptococcus pneumoniae. That is the most common organism. So hospital acquired pneumonia in the sense, here it what is meant by hospital acquired pneumonia means, so if the once the person get admitted in the hospital after 48 hours, if the person getting any signs and symptoms like a fever, suddenly the person become a, getting developing the pyrexia and then the crepitus sounds, everything you are getting, and then so at final your rule you are going for the diagnostic evaluation, there you are finding any pneumonia related means that is the hospital acquired pneumonia. The term is most important. The definition, appropriate definition is once after 48 hours of the hospital administration, if the person getting the pneumonia means that is the hospital acquired pneumonia. Here the common organism are MRSA. MRSA means methicillin resistant staphylococcus aureus or ESBL. ESBL means extended spectrum of beta lactamase. This is MRSA and ESBL. The other organism are the Streptococcus pneumoniae, Staphylococcus aureus. Those are also causing the hospital acquired pneumonia. And the third one is a ventilator associated pneumonia. The same definition. Once after 48 hours of mechanical ventilator, if the person suddenly getting the signs and symptom and then you are ruling out the diagnosis of pneumonia means that is the ventilator associated pneumonia. Then according to the area of which area of the lung affected, based on that we are classifying three things, that is a bronchopneumonia, lobar pneumonia, interstitial pneumonia. Broncho means inner wall of the bronchus get affected. Lobar in the sense that will affect the lobe. So right lung we have a 3 lobes. So if the upper lobe get affected, either it may middle lobe or lower lobe. So left lung means upper and lower lobe. Interstitial means that is the area between the alveoli. So that is called the interstitial pneumonia. So according to the causes wise, aspiration pneumonia and the necrotizing pneumonia. What is meant by aspiration? Aspiration means inhalation of anything apart from the breathable gases. So inhalation of anything apart from the breathing gases, it is for the aspiration. So here it may be any foreign particles, or here it may be any gastric content or any oropharyngeal and nasopharyngeal secretions. So lot of things. This is aspiration pneumonia. Necrotizing pneumonia means that will form the local necrosis, and then that will form the cavity like a thing. That is the necrotizing pneumonia. So these are the various classifications. So in the risk factor wise, older adult, people with chronic illness, active smokers, anyone who is not ventilating effectively, who has excessive secretion, person with COPD, asthma, post-operative patient, or a person who is bedridden, sedentary, and then immunocompromised cases like HIV, other illness, post-transplantation, immunosuppression or chemotherapy drugs. These are the some risk factors for the pneumonia. And then assessment wise, usually this is the thing, as mainly what we are focusing. So assessment or management, we have to follow that, our scene size of scene safety, everything, that is a standard assessment. But what we are focusing in pneumonia means usually report several hours to days of the weakness, productive cough, fever, and then sometimes chest pain worsened by the coughing. So the person will complain, they will it is not a suddenly development, it may start suddenly, otherwise it may gradually develop. That is the, in pneumonia cases, the person day by day their condition will worsen. So day by day their fever history, otherwise the coughing history, day by day get worsen. So in physical examination wise, in inspection part, you can find the grievously ill and toxic appearance, may or may not be coughing, dehydrated state. Sometimes the person oxygen saturation will be significantly lower when they lie on the one side versus the others. So if the person lying on the affected side means, then you will get a lower hypoxia state. If other side, if he is lying means, there will be a normal level. That's another thing we can monitor in the inspection state. Percussion state wise, increased tactile parameters. So tactile parameters, we know that is the vibration test. We have to ask the person to tell something like a 99, 99. Then you have to check the vibration of the chest. So it will be a more resonant in the pneumonia cases compared with the normal healthy individuals. That is the increased tactile parameters. Auscultation wise, here you will hear the crackle sound, bronchial and then bronchiovesicular sound, that will be in the affected consolidated area, and then pleural friction rub also will hear. So crackles means crackles, so think it is the alveoli. Alveoli, here we told it is a inflammation and then consolidation. Consolidation means the fluid filled alveoli. So what will happen means, this is the closed fluid filled alveoli. In the time of inhalation, at the peak status, means at the peak stage of inhalation stage, your alveoli will pop out to open. So the pop out sound will be here as a crackle sound. So simple. So it is the alveoli filled with an fluid. So at the peak of inspiration, your alveoli get pop up to open. So it will give us some pop up sound. While opening, it will create a one pop up sound. That sound is heard as a crackles. Okay. So bronchial and bronchiovesicular sounds means, in our assessment part itself, we told, so tracheal sound, it will be like this. So tracheal sound, it will inhalation and then one minus drop and then exhalation. Both will be in a same duration and same intensity, little more louder. And then second is a bronchial sound. Bronchial sound, inspiration is shorter and then expiration is longer. And then second is a bronchiovesicular sound. Bronchiovesicular is an inspiration, expiration both in same duration, but here the intensity wise, compare with an trachea, bronchial intensity less, minimally less. Compare with an bronchial to bronchiovesicular still more less than the bronchial. Compare with, finally vesicular, there you will get a increased inspiration and then decreased respiration. The duration will, for the exhalation duration is less compared with an inhalation. here also you will get a still more faint like a sound. So it will when you are auscultating vesicular part means that is a sound like a faint. So these two sounds you will get in the consolidated area, bronchial and then bronchiovesicular sound. So pleural friction rub also we can hear over the pleural region. So how we can differentiate means if the person stops, if ask the person to stop breathing while the time of if you auscultating means you won't hear any pleural friction. Pleural friction. Pleural friction happening because of the breathing movement. There will be some friction sound. So if the person stops breathing means there won't be no more the friction. So you won't hear the pleural friction. So these are the some common assessment point in cases. So management wise same thing, scene size up and then scene safety, form a generalized impression, assess the mental status, assess and treat the life threatening causes. Here the proper approach in the pneumonia is we have to treat the continuous antibiotic therapy, then only it will resolve. Sometimes the person may need the intensive care observation also. In definitive care, the person may need the intensive care observation. But in the field we can do something in acute crisis cases. We can rehydrate the person, we can give the oxygen, we can manage the secretion management we can do, and then bronchodilator usually it won't help in the case of pneumonia cases, but in acute crisis cases it gives us some hands to the ability to the ventilate. It will have some minor portion, it will help us. So apart from this, bronchodilator won't have that much of effective in this case. So we have to transport to the appropriate medical care. So mainly we are focusing on rehydration either by the oral, otherwise if the person is not intact gag reflex means then you are going with an IV fluids, oxygenation and then secretion management, because we told any gastric content, otherwise any oropharyngeal, nasopharyngeal secretion that may go into the lung and then it may cause the aspiration pneumonia. So that part you can manage. Any bronchodilator if you want means we can go with an bronchodilators, then we have to transfer the appropriate medical care. So second condition is a Atelectasis disease. So Atelectasis disease in the sense it is a complete or partial collapse of a lung or a section lobe of the lung, that is called the Atelectasis disease. So it's a complete or partial collapse of a lung or section of the either upper lobe or middle lobe, lower lobe, likewise lobe wise collapse of the lung. So what is the pathophysiology behind it means? So in a healthy individual, we know we have a billions of alveoli in our lung. So it is more common for some of them to collapse from the time to time. So means, so we have a billions of alveoli. In this, some of the alveoli naturally it will collapse. So collapse in the sense that will pinch and shut down. So it will pinch and shut down. That is called collapse. So so when the time of collapse, usually will the humans periodically sigh, cough, sneeze and change the position. All the actions that are thought to help to open the closed alveoli. So these are the closed alveoli. Naturally, the shut will happen. So on the time we are coughing, we are sneezing, and then we are changing the position. These are the actions they are thought to help to reopen the collapsed alveoli. So by the time of coughing, the collapsed alveoli gets reopened. That is the normal physiology. But if any problem in sighing, coughing, sneezing and changing position means that will affect the closed alveoli to reopen. So means here this is the process that helps to reopen the alveoli. If anything a problem in the coughing, those are the things means that will prevent the reopening of the alveoli. That's why we are mentioning when the person doesn't use these actions like coughing, sighing means, for example, because they have become a sedated, either we may induce the sedation, otherwise already the person in the unresponsive state like a coma, otherwise if the person have a because of the deep breathing or that moving cause pain like a restrictive lung disease, means any trauma cases, any flail chest, if the on the time restrict lung disease, the person they won't take adequate amount of breath, because taking a deep breath that will cause some more pain. Because of the pain panic, they won't take the more depth of the breathing, they won't take. So that is the thing. any because of the deep breathing or moving cause the pain, restrictive lung disease. These are the things that will increase the numbers of alveoli may collapse and not to reopen. And then it is alveoli like a balloons. So once if gets completely collapsed means it's more difficult to blow open. Once they have completely collapsed, eventually entire lung segment collapse. So alveoli is like a balloon. So once the balloon is overly deflated means, so it is more difficult. So while the time of blowing balloon, it is a flat completely deflated means initially we have to blow much more effectively. So once if get it blown means then we can easily blow. So once if get it inflated means then it will be easily we can blow. So likewise alveoli, once if collapsed completely means the initial thrust is we have to give the more pressure, then only it will open, and then it will coming into the functional. That is why we are mentioning in the atelectasis. And then atelectasis causes wise two things. So we told this is the alveoli, this is the airway. So two major causes, obstructive and non-obstructive. Obstructive in the sense, so here if any tumors or if any aspirated foreign bodies or any mucus plug or intrathoracic tumors. So if anything happen means what will happen, the air unable to approach the alveolar side. So unable to approach means there won't be a inflation, so there will be a collapse of the alveoli. So this is the obstructive causes. Second thing is a non-obstructive. Non-obstructive means there won't be a problem in the airways. So nicely that air can reach the alveoli, but the causes in the external pressure. So here the air is reaching out the alveoli, but the cause is externally something is resisting the expansion of the alveoli. Externally some pressure is putting over the alveoli that will resist the inflation of the alveoli. That's the causes like a hemothorax, pneumothorax, ilothorax, and then you can tell us a flail chest or restrictive lung disease. Those are the comes under the category of non-obstructive external pressure causes. And then assessment wise, here affected area become a breeding ground for the pathogens that resulting in pneumonia. So pneumonia also in risk factor we told inadequate ventilated person is the one of the risk category for the pneumonia. So this is the thing, inadequately ventilating person. And then this is the concern in any patient who has a fever in the day following of the chest abdominal surgery, particularly if the breath sound are decreased or abnormally colored sputum is produced. So in atelectasis, so the history is most important to rule out the atelectasis. In this case, the person may complain the fever, and then they may complain the dyspnea, and then they may complain with the colored sputum, abnormal sputum production. So in these cases, you have to ask for the history of if they gone through any chest or abdominal surgery in past 1 or 2 weeks, that we have to ask. Second thing, if they involved any trauma, that we have to ask. And then if they have any previous history of atelectasis disease, that also we have to ask. So here history is a most important thing in the view of infection like a pneumonia, and in the view of primary pathological condition like atelectasis disease. So how we have to manage? If a post surgical patient means, we can ask them to the cough or deep breath or get out of the bed with the assistance. If possible means we can change the position, because these are the things only reopening the alveoli. So that is the thing we can do. Otherwise at the medical facility in definitive care, what they are doing means they constantly encourage the patient to take the deep breath. So that is the one of the treatment. Otherwise a device called the incentive spirometer. So this is the incentive spirometer. So we are more familiar with that. Here we have a 3 balls, and then we have to inhale, and then we have to exhale. That is the thing we are using. So here incentive spirometry also we can use. So using a incentive spirometry, so we have to advise in a proper manner. So how we have to use the incentive spirometer? Here you can see this is the normal position. This is the normal position. In pictorial demonstration we can see this is the normal position. So you have to ask the person to hold like this, and then the mouthpiece fully inserted in the mouth, tightly closed, slowly and then slow and regularly ask the person to inhale. So that is most important. Slowly and regularly the person should inhale the thing. So by the way the person can see the elevation of the ball, okay, in this position. If you are inverting the tube, so inverting means the mouthpiece goes up. So if you are inverting the tube means the ball comes down the same position, the mouthpiece comes upper side. So here the person slowly and steadily he have to exhale. So in this position he have to inhale, in inverted position he have to exhale the breath. So that is the way. Here the do's and don'ts is the person should not inhale and exhale too fastly or quickly, too quick manner. They should not. Ask the person in slowly and regularly. That is the most important thing. The other important thing is with this position means we told no, with this position we have to slowly inhale. Some rather cases the person with this position they will exhale the gas and then they will tell the manufacturer defect of the device, like that they will tell. So they should not. Clearly explain the person. With this position means slowly and deeply inhale. Inverted position means slowly and deeply exhale the air. So that is about the atelectasis. And the third one is the cancer. So cancer is the most common. Lung cancer is the most common in the tumor cases. More specifically among people who smoke cigarettes or second-hand smoker, active and passive smokers, and those exposed to the occupational lung hazards like asbestos and then coal dust. So asbestosis, those are the things. So if we are exposing those are the coal dust, and then active and then passive smokers, those are the some risk factors for the lung tumors. So in lung tumor assessment wise, it is most oftenly identified with when a tumor is large. So assessment wise, lung cancer is often identified when tumor is in the large airways that will bleed, and then that will causing the hemoptysis and then uncontrollable coughing. Because of the irritation, the person will have a uncontrollable coughing. It also accompanied with an COPD and then impaired lung function. If it is inward into the lymph node in the neck, so if it is inward in the lymph nodes in the neck means that will partially or completely obstruct the upper airway. The upper airway obstruction will happen. So tumors or treatment may also cause the pleural effusion, which can present with a rapidly progressing dyspnea. So with the tumor, the treatment for the tumor like drugs, chemotherapy drugs, that will cause the pleural effusion, and that the person suddenly they will develop the dyspnea. So with the dyspnea itself, they may approach for the emergency medical service. In pre-hospital care, how we have to tackle over the dyspnea, those are the things we should know. And then management wise, in this cases we can, paramedics can support oxygenation, ventilation and provide some amount of pain management. So again oxygenation is different term, ventilation is different term. So oxygenation means this is the hemoglobin, so loading of oxygen molecule onto the hemoglobin. So you see hemoglobin, loading of oxygen molecule onto the hemoglobin, it's called the oxygenation. So ventilation in the sense air coming in, going out. So so think like a ventilated room. When you will call like a ventilated room, so the air should come in and then some air should go out. Then only we'll call the ventilated room. No, that's same thing only. So ventilation means air coming in and then going. Coming in means coming into the lung, and then air coming going out from the lung, that is the ventilation. The other term is there, that is called respiration. So respiration in the sense, here it is the alveoli, here you will have a capillaries, there will be exchange of gases. So the exchange of gases here, in normal physiology what will happen, from the alveoli to capillaries O2 will transport, from the capillaries to alveoli CO2 will transport, that is the that is the part of respiration. In respiration also we have a still more two condition. We know external respiration, internal respiration. The other name for external respiration is a pulmonary respiration. The other name for the internal respiration is a cellular respiration. No, so if the gas exchange occurs between the alveoli and then pulmonary capillary, means that is the external or pulmonary respiration. Internal or cellular respiration, in the sense there will be gas exchange between the cell and the cellular capillaries. So why we came here means oxygenation, ventilation. So oxygenation, loading of oxygen molecule, ventilation, they are coming in, going out. So both are the different term. Why this is why we went those are the stuff. So some amount of pain management also we can provide in the pre-hospital setup. Sometimes with this emergency, and then sometimes they may call for the dyspnea also. So dyspnea in the sense we have to position the person, and then we have to give the comfortable position, and then still we can administer the oxygen. So those are the supplemental oxygen you can do. Those are the little things we can do in the pre-hospital. In hospital, based on the pleural effusion state, they will treat the thoracocentesis or needle aspiration. Those are the some a definitive treatment they will go for. In pre-hospital, this is the thing we can do. Sometimes you may call to assist the end of life consideration for the patient with the cancers. So not around the emergency, with the end of life consideration also you may call for. Those are the things. Suddenly the person gets the respiratory depression because of the large amount of narcotics. Narcotics mainly they will use in the chronic pain condition, any anxiety for other symptoms. In this respiratory depression, the only treatment is we know for opioid overdose we are giving the naloxone. So naloxone you can give. So here the naloxone, the action of the naloxone is it will reverse the respiratory depression. It won't reverse anything. It will reverse the respiratory depression. That is the only action of naloxone. Here we should not completely reverse the patient primary pain control. So the person is complaining respiratory depression. So you are identifying the person in the narcotic overdose. So we are treating with a naloxone. Here you should not withdraw the whole primary pain control medication. So you should not withdraw the whole primary pain control medication. Simply you can treat with a naloxone, take him to the appropriate medical care, and then the remaining things and all they will take care. So here aerosol device also it will suppress the chronic coughing in patient with the end stage of lung cancer. These are the some prescribed medication they will be they were have in their hand. So you can use those are the things to treat the cancer, and then to acute crisis of the cancer we can treat. So do your best. Shalom.